only in the front. In the frontal left-sided leads, sir, there are epileptiform discharges in the form of polyspikes, which are present only on the lateral.
So these are generalized delta brush waves. The delta, because the frequency is 3 Hertz, and brush is the multiple small spikes which are depicted by the arrow.
So this is an extreme delta brush pattern, which is fairly specific to autoimmune encephalitis. Next. So what is the role of EEG in diagnosis of seizures, oblique medical conditions? Abhishek, quickly.
The EEG first can rule out whether it's a PNES or GTCS.
So always remember that EEG is not used to rule out PNES and GTCS. So it is not a mandatory investigation. It can support you, but it may not rule out.
So the pattern of the localization of the epileptic, the waves
so
which is present,
localize
the lesions.
Localize a seizure from where it is arising.
Yes, sir.
Or
and the pattern also which is coming, the leads can also mimic.
So it can be either diagnostic, mostly it is diagnostic. So there are specific patterns on EEG which can help you give a diagnosis. So such as lateralized epileptiform discharge.
In HSV.
They are most commonly used. So they are mainly seen in HSV encephalitis or periodic discharges seen in CJD or SSPE. Or you can diagnose certain epilepsies such as 4 to 6 Hz generalized spike and wave disease patterns.
You can also
always remember that a normal EEG doesn't rule out a seizure or epilepsy. There are many areas of the brain which are not represented on a
EEG
on a surface EEG. You need to do special EEGs for that. Please. Next.
The MRI brain T1 weighted axial and T2 weighted axial and flare axial showed focal encephalomalacia in the left putamen region, probably post-varicella infection. Her investigation for CSF and serum antibodies was sent, and it was positive for NMDA, respectively. So she was diagnosed as a case of autoimmune encephalitis with NMDAR positive.
Any pathology testing? So what are the various antiviral antibodies you know?
GM2 antibodies, sir. GM2 anti-G antibodies.
So is there any way you can classify them?
Intracellular and sensors.
So there are, there are daily 1 or 2 antiviral antibodies which are discovered. So there are certain some of them which are classical, some of them which we don't see very commonly. So they can be divided into antibodies against intracellular antigens, or antibodies against synaptic receptors, and antibodies against the channels and other cell surface proteins. The clinical implication is that the antibodies which are against the intracellular antigens, they are generally seen in paraneoplastic syndromes. They don't respond very well to the treatment. The other ones, the antibodies against synaptic receptors and antibodies against the ion channels, they may or may not be associated with an underlying malignancy, and they respond well to IVIG or steroids or to higher immunosuppression. Radiology testing. So though the MRI, any radiology testing? So though the MRI of this patient was normal, and this patient has been diagnosed as autoimmune encephalitis, so there are certain patterns which are shown. So you take on each one turn by turn, and you tell me which of the autoimmune encephalitis or mimics presents as limbic pattern.
So limbic pattern, usually most of the autoimmune encephalitis present with a limbic pattern, sir.
No, they are very specific nowadays. You have to tell me which type of autoimmune encephalitis presents as a limbic pattern involved.
So the limbic pattern can be, sir, NMDA receptor.
The limbic pattern is generally seen in anti-LGI1, or could be just a post-ictal phenomenon, or in cases of street or previously called as Hashimoto's encephalitis. Next, Ayush. Anybody else? Anybody other than you who is there? Radiology? Please stand, I can see you here. Yeah. So striatal pattern is seen in which kind of autoimmune encephalitis?
The title is CR.
Yeah, good.
Yes,
So
CAD.
this includes CRMP and a differential diagnosis is CJD. Perivascular pattern. Please. So the perivascular pattern is seen in NT. GFAP is a new entry that has come in, or in cases of neurosarcoidosis. Then there is a diencephalic or basal pattern which is seen in NT-MAR2 or infections such as listeria or Behçet's disease. Then there is a cortical pattern which is could be any infectious encephalitis or anti-GABA receptor encephalitis, or there could be an MRI negative, so which is normally seen in NT-NMDR. Next. So are there any newer imaging modalities? Are there any any newer imaging modalities that you can use? Suppose the MRI is negative.
So ASR perfusion can be used.
So good. Welcome. So ASL arterial spin labeling, it has got a wide application, especially it is helpful in NT-NMDR and LDLGA1 where you don't find anything on conventional MRIs. Next. So now there is a role of FDG PET CT in autoimmune encephalitis. Okay. So it detects the metabolic abnormalities. There are specific patterns which are associated with specific types of autoimmune encephalitis. And it is useful in the sense that coexisting neoplasms, they can be detected and response to treatment can be evaluated. But the limitation is that it should always be interpreted in conjunction with clinical presentation, other imaging studies, and serum autoantibodies. And it is considerably more expensive than other imaging modalities like MRI. So, Sridhar, when will you suspect autoimmune encephalitis?
First thing, sir, the patient is having earlier onset, and especially in female population, and patients who are refractory to routine medical anti-seizure medications, and positive family history.
Whenever there is a rapidly progressive cognitive dysfunction, there is a personality disorder, there is a new onset movement disorder, the patient has got refractory status epilepticus, or they've got multiple movement disorders occurring in the same patient, there is multiple neuraxis involvement, and there is some history of autoimmune potential in the family. Next. So there are few diagnostic criteria for autoimmune encephalitis. So this is for anti-NMDR encephalitis. So it is one of the 6. Either the patient got seizures, speech dysfunction, movement disorders, decreased level of consciousness, abnormal dysfunction, or abnormal behavior. And the onset has to be rapid. Generally, they say what symptoms have to be there. Or if the patient has already a known case of ovarian teratoma, then only 3 symptoms are required. And at least one of the either the CSF has to be abnormal or the EEG has to be abnormal. So if we apply this to our patient, she satisfies almost all the clinical and lab criteria till now. We have recently excluded the alternative causes, and we've also got antibodies which are demonstrable in both the CSF and the serum. So why do you think that this entity of antibody negative but probable autoimmune encephalitis is available? See, all these antibodies, they take a lot of time to come. They are not very easily available. So if you send them today, it might take 2-3 weeks and start treating them as soon as you have suspicion. So that is why there is an entity called as probable autoimmune encephalitis or antibody negative autoimmune encephalitis. Again, there has to be rapid progress within 3 months of the symptoms mentioned in the previous slide. And either the MRI is abnormal or the CSF shows neurocytosis, or if you can get a brain biopsy done which shows vitamin filtrates, and you exclude the other etiologies. And they don't fit into any well-defined autoimmune encephalitis system. So if you get these things, you can straight away start them on treatment. Next. So anti-NMDR encephalitis are generally seen in young females. 94% of the cases that are associated are ovarian teratomas. Up to 2% can be extraovarian teratomas. HSV infection, HSV encephalitis is known to trigger anti-NMDR encephalitis, and they can also present with negative malignant syndrome. We already have had a couple of cases which are primarily presented as negative malignant syndrome. Next, there is a natural history of anti-NMDR encephalitis. There is a viral program may not be there. So 1 to 2 weeks or weeks to months, predominantly the psychiatric symptoms they predominate. So that is why many of them would land up with a psychiatrist first, and then they would be referred to a physician or to a neurologist. Next.
She was managed with methylprednisolone pulse with 750 mg IVOD for 5 days and 5 cycles of therapeutic plasma exchange and 2 doses of injection rituximab, 500 mg IV at 14 days interval.
So this is how you treat autoimmune encephalitis. One is the symptomatic treatment. Always remember, you may try to control the seizures with anti-epileptic drugs, but they will not respond unless you address the underlying pathology. The first line treatment is corticosteroids, IVIG or plasma exchange. In case they don't respond, then you can go to rituximab, mycophenolate or alpha. Next.
So she was discharged on steroids, the anti-seizure medications, and other management. Her present status is the mini mental state examination scores to 27 by 30.
Hi, my name is Zareen. I am currently studying in Nikos Public School. I am in 9th grade. I was recently diagnosed with a disease called autoimmune encephalitis. I was
That her cognition has come back, but she still has got some speech difficulties, and most of them will be left with some or other deficit. So special acknowledgements to Department of Psychiatry, FMCA Command, to Southern Command. The take-home message is that not every psychiatric presentation is due to every psychiatric illness. Please always rule out organic cause for a psychiatric presentation. Early recognition can save the brain. And autoimmune encephalitis, this girl had a very good family support, social support. So it needs constant emotional support. Next. The aim was to discuss approach to a patient mainly presenting as a neuropsychiatric manifestation to differentiate between primary psychiatric and organic causes of symptoms based on distinct clinical examination and to sensitize our residents about autoimmune encephalitis and the challenges that we face in the diagnosis. So we finished. Any questions from the residents?
Colonel Manish, because of paucity of time and the anesthesia CME to take place, I think we'll wrap it up. We'll request Dean Sir for any comments.
Yeah, Manish, I just wanted to say that among the various radiological classifications that you showed the pattern, so among them, differentiating, suppose you have 3, so among them, one or the other depends upon what other associated findings you will have. Like for the striatal one in CJD, you will probably have the thalamus involved, and in the other differentials, you will not. Or in the medial temporal ones, if it is HSV, you will have cingulate, others you will not have. So nicely done.
Thank you.